So good morning. Now, continuing with the MET story, I'm going to talk about the third agent, what we have, which is Capmatinib. Now this is a poster I was supposed to discuss, which is a recent presentation in one of the meetings. Now we know Capmatinib and Tepotinib or Amivantamab, how these agents evolved into this space. They were initially MET was thought to be an important resistant mechanism for patients who were getting anti-EGFR therapy. And initially the thought was, okay, once they progress on osimertinib or drugs like that, things like savolitinib and a lot of other MET inhibitors were tried. And initially, in order to understand which is a subgroup of patients where they are most effective, is MET amplification important? So studies like this Geometry Mono 1, which actually had a lot of cohorts, and the way the cohorts were divided were based on these patients had prior treatment or no prior treatment, and then also whether these patients were selected based on just increase in gene copy number, or later on when we figured out that this MET exon 14 skipping is actually the real target, then they made two cohorts, which was if you see in that in the trial schema here, I know you can't read from there, but the cohort 5B was a treatment naive cohort with exon 14 skipping mutation. And then when the approvals came and this thing was the studies were carried forward, the companies have dropped amplification or gene copy number as a biomarker, and we are now specifically looking at MET exon 14 skipping mutation, which seems to be a true driver mutation, what we have seen with ALK or EGFR, looking at the results so far. So in this Geometry Mono 1 longer follow-up, the follow-up here is up to August 2020, we have about 79 patients, and these patients all have come from 4 different cohorts. Now for the audience, you just have to look at 2 cohorts were previously treated patient and 2 cohorts which were treatment naive. That means no prior MET treatment. As Rishabh showed, that if you had taken a MET treatment before, drugs like Amivantamab have a very modest response rate, only 10 to 17%, as opposed to 50 or 60% what we have seen with other agents like Amivantamab or Tepotinib upfront. So how does Capmatinib data hold in this space? So what the kind of patients what we see with this mutation, they're a little older. See, the median age is about 71, right? So this is not your young non-smoker female or male who have these mutations. These are older people. Smokers, about 30 to 40% of them are smokers. And also another thing to note is that it's not only seen in adenocarcinoma. You can have about 10% of patients with squamous or adenosquamous. So this is something which you should be looking at in all NSCLC, not only in adenocarcinomas. Now, brain metastasis at baseline is not so common, not like what we see in ALK. Now, so when this drug Capmatinib 400 mg BD, if you look at the waterfall plot, the good thing is that most patients do show a shrinkage on the scan. Hardly any patients who have had progression or did not benefit. But if you draw the line at the RECIST criteria for partial response, which is the commonest response, what you see, it's to the tune of if you see here, partial response 64%, 65%. So 60 to 70% partial responses, and the rest of the patients also show some shrinkage. Now the question is, these responses, how durable they are? What is the median progression-free survival? So the median progression-free survival is about, if you see here, 12.4 and 12.3 versus 5.4, 6.9. So if you are treatment naive, you get almost a year of median progression-free survival, which is what you get in drugs like Gefitinib or Erlotinib. So this is like a real target which can give you a durable progression-free survival. And now we have these overall survival curves also with this longer follow-up. And if you see in patients who have been treatment naive, the overall survival here is about 20.8 months. So which is again a pretty respectable figure in these patients who had no other targetable options. Now, do these patients have other options? Like, can we use if they are PD-L1 high expressors, can we use chemo, immuno? Yes, that remains an option. I mean, if you search PubMed, you'll find papers who have described pembrolizumab activity in MET exon 14 skipping mutation with PD-L1 more than 50%. Overall, the take home from this is that Capmatinib along with Tepotinib seems to be good options for these patients. Would you use it in treatment-naive patients upfront or after chemo-immuno? That is an open question. Would you still use like one agent after the other? Now, it's not that you can't use it, but then expect response rates only in the range of 15 to 20% and not more than that. And the responses here seems to be durable with a median PFS of about 1 year. In terms of toxicity, now these are well-tolerated drug. The class effect of MET inhibition usually is edema, and then with Tepotinib we see more diarrhea. Thankfully, not much diarrhea here with Capmatinib. And the rest of them are some visual changes, decreased appetite, fatigue, and dyspnea. Overall, this seems to be a good package. If your patient can afford it, this is a good treatment to give either upfront or after chemoimmunotherapy. Thank you.